Okay, we're going to go ahead and get started. Hello, everyone. Thank you all for joining another Outcomes for Me webinar. Today, we are delighted to welcome Director of Clinical Trials and Breast Oncologist, Dr. Sarah Tolaney from Dana-Farber Cancer Institute. Dr. Tolaney is joining us to provide information and updates from the European Society of Medical Oncology meeting that was held a couple of weeks ago. The research studies shared at conferences like ESMO often become the basis of clinical guidelines updates. So I'm delighted to have Dr. Tolaney join us today. My name is Maya Saeed, and I am the co-founder and CEO of Outcomes4Me. Outcomes4Me wants to help and empower breast cancer patients with the tools and resources to better navigate their care. Through our mobile app, patients can have access to free resources and information, including clinical trials, to help them manage their disease. The format of today's discussion will be a bit different from the format we've done in the past. We're going to start with the presentation, and then we're going to have the Q&A discussion. We've got a few questions from our users prior to this webinar, but we encourage everyone to send us questions via Zoom or Facebook Live, and we will do our best to get them answered during our time together. I want to start off by allowing Dr. Tolaney to give a brief introduction about herself, and we'll jump directly into the overview presentation and then to the question. Dr. Tolaney.
Oh, thanks so much for having me, Maya. My name is Sarah Tolaney. I'm a breast medical oncologist at Dana-Farber Cancer Institute in Boston, and very happy to be here today to share some of the exciting data that came out from the recent ESMO meeting. So I think as many of you know, there are a few different large oncology conferences that occur over the year where a lot of data gets presented. And as Maya alluded to, a lot of data that emerges can potentially be practice changing. And so it is very exciting to see as new therapies come out. So today we're going to touch upon some of the exciting data that came out at the meeting, and at the end we can return and take some questions. So given all the challenges with COVID, this year's meeting was a virtual meeting, and I think the ESMO group did a wonderful job putting together such an incredible virtual platform for it. And so what we saw at ESMO for early stage breast cancer really focused on a class of drugs called CDK4/6 inhibitors. So these are oral drugs that really look to halt the cell cycle. And when these drugs have been added to hormone therapies for metastatic hormone receptor positive disease, we have seen that they have dramatically changed outcomes for patients and really have become a standard in metastatic disease. And so the question was, while this works to help keep disease controlled significantly longer in patients with metastatic disease, would adding these drugs to hormone therapy in patients with early stage breast cancer actually prevent the cancer from coming back? So can we reduce rates of recurrence for early stage hormone receptor breast cancer patients by adding this new class of drugs? And so as many of you may know, there are lots of different drug companies that make these kinds of drugs. So there are actually 3 different CDK4/6 inhibitors. But at ESMO, we saw data from trials that looked at 2 of these agents. So one trial that we'll talk about is called the PALLAS trial. This looked at adding a CDK4/6 inhibitor called palbociclib to hormone therapy and seeing if it could prevent recurrences. And then the other trial that we'll talk about is called MONARCH-E, which specifically looked at a drug called abemaciclib and looked to see if it could prevent recurrences. And there are some differences in the trials that we'll also talk about, which may have impacted some of the outcomes that we saw. So the first study that we'll talk about is the PALLAS trial. So this was a trial that was really for patients who had stage 2 and 3 breast cancer that was hormone receptor positive and HER2 negative. And patients were randomized to receive the hormone therapy that their oncologist thought was appropriate for them with palbociclib for 2 years, or to take the hormone therapy alone. When you look at the types of patients that enrolled onto this trial, you can see that it was a variety of patients. So some patients had sort of more early stage cancer, so what we would call stage 2A cancer, where there is not lymph node involvement, but is a tumor that's over 2 centimeters. and that was almost 20% of the population. But then they tried to look at what they considered patients who may be at a higher risk of recurrence based on the amount of cancer that had been found. And they considered about 60% of the patients having what they classified as high risk disease. And this meant that those patients had more than 4 lymph nodes involved at the time of their surgery, or if they had 1 to 3 positive lymph nodes, that they had to have some other feature that was high risk, meaning that they had to have a tumor that was over 5 centimeters, or the tumor had to be high grade, and then they would classify them as having what was called a high risk cancer. So it was 60% of the patients that classified as high risk, meaning 40% didn't meet those criteria. So when they looked at outcomes for these patients, they found that adding the palbociclib did not impact outcomes, meaning that there was no reduction in risk of recurrence. And I will say this was very startling to many of us because we've seen such large benefits for patients with metastatic disease. I think most of us, including me, anticipated that adding palbociclib here would be very beneficial. And so this was, again, pretty shocking to us. The group even tried to look to see, well, maybe it's because the population was sort of a diverse group of patients. Maybe it's that the drug helped some patients and maybe not others. So they tried to look at different characteristics of the patients that participated in the study to see if there was any difference in outcome, particularly looking at those high-risk patients versus what they considered lower-risk patients. But even when you subdivided people into different groups, they weren't seeing benefit from palbociclib in any of these groups, which again was surprising. One challenge with the trial is they found that a little over 40% of patients actually didn't complete the 2 years of palbociclib. So they did have to stop the drug early, and the majority of these discontinuations were due to adverse events. So that meant that with 42% of patients stopping drug early, that almost half the patients didn't actually get all of their 2 years of treatment. And I think that's made many of us question if that could have influenced the outcomes of this trial. If you're not getting the drug in, you're not likely to see a big benefit. And so perhaps that is part of the problem. So I think in conclusion from the trial, basically they're finding that adding palbociclib is not reducing risks of recurrence, even when you start separating out patients into different subgroups. There wasn't a subgroup that could be identified that benefited from the palbociclib. And while they didn't identify any new side effects, they certainly did find that the side effects, particularly the neutropenia that's seen with palbociclib, did lead to discontinuation of drug in a large proportion of patients in this trial. And again, I think that does have to be taken into account when interpreting the findings from this study. So these results stand in quite large contrast to what we see from the MONARCH-E trial, which looked at a different CDK4/6 inhibitor. In this case, the drug's called abemaciclib. This study was a little different in that it specifically only enrolled what they considered high-risk patients. So while the PALLAS trial was a little bit broader in its eligibility for stage 2 and 3 disease, this was more narrow in that it only included those patients that we had alluded to were classified as high-risk disease, meaning having more than 4 lymph nodes, or if you had fewer than that, if you had 1 to 3 positive lymph nodes, you had to have a tumor over 5 centimeters, be high grade, or have something else called a high Ki-67, which looks at sort of the proliferation of the cancer. And so again, the trial was just limited to what they classified as high-risk patients, and then they randomized them to receive the hormone therapy of their physician's choice with abemaciclib for 2 years, or to just receive that hormone drug by itself. And here you can see that the trial population, again, is a little different than PALLAS because, again, now all of these patients meet high-risk characteristics. That in general, almost all patients in this trial had received chemotherapy for their cancer, so 95% of patients had received chemotherapy. And then here's just a breakdown of the patient characteristics that we were alluding to by high-risk status. So about 60% of the patients on the trial had met eligibility by having 4 or more positive lymph nodes, whereas about 40% had 1 to 3 positive nodes and had met the other criteria for eligibility. And here are the efficacy outcomes. So here you can see that adding abemaciclib to the hormone pill did actually result in a reduction in risk of recurrence with about a 25% relative risk reduction, which translated to about a 3.5% difference between the two arms of the trial. So what we would consider statistically significant. I think one does have to be a little cautious though, because this is very early data. Patients have only been followed on average for about 15 months. And so we do know that, unfortunately, recurrences from hormone receptor positive breast cancer, can occur at any time. That being said, for patients with high-risk disease, it's thought that the majority of those recurrences will happen earlier rather than later. And so, I think these findings do have implications because we are seeing that it is reducing risks of recurrence in this high-risk population, although be it at this early time point. So then when this trial looked at outcomes by the different subgroups, again, the question was, are there patients who are not benefiting, and are there patients who are driving even more benefit? And in general, you can see that all patients generally benefited from the use of abemaciclib. The trial does have this slight trend towards saying that the premenopausal patients may have had even greater benefit than the postmenopausal patients. But again, hard to draw any definitive conclusions because both populations are benefiting. Given the data from PALLAS showing the high rate of discontinuation with palbociclib, obviously that was also of great interest in this trial. At this point in time, when they analyzed the data, 16% of patients had discontinued their abemaciclib early, meaning they did not complete their 2 years of therapy. However, I think one has to be cautious because this trial only has 15 months of follow-up, and so about 3/4 of the patients are actually still taking their drug. So it is possible that as time goes on, this rate of discontinuation will go up because, again, we're just in the middle of their therapy still. So I think what we're seeing, though, is that we are seeing a benefit from the addition of abemaciclib at this early time point where we're seeing fewer recurrences occur in patients who got the abemaciclib with the hormone compared to the hormone therapy alone, and that this risk of recurrence reduction is predominantly occurring in liver and bone metastases, so preventing really distant recurrence, which is very important. And, obviously one has to take into account side effects when making decisions about whether or not it's worthwhile to take these drugs. And the major side effect seen with abemaciclib has been diarrhea. But that being said, it was manageable, and the rate of discontinuation, at least to date, hasn't been very high. So, I think it does seem like it is something that can be managed. There was an interesting finding with the toxicities, and I'm not quite sure what to make of it, but there actually were fewer instances of patients experiencing arthralgia, so joint aches and hot flashes when they were on the abemaciclib with the hormone compared to the hormone alone. And it's made one wonder, what is abemaciclib doing to reduce the frequency of the side effects that we typically see with the hormone therapy? And, one could say maybe this is just chance, but it actually also was true in another study done with abemaciclib and hormonal therapy, making it seem like it's not just chance, that this seems to be a consistent trend. And so I think a lot more work is going to need to be done to figure out why that may be the case. So I think this has led to a lot of questions. And one of the main questions is, why are there such different outcomes? Both of these are drugs that have worked very well for patients with metastatic disease. Why are we seeing one have benefit and the other one not have benefit? One theory is, well, maybe it's just the patient populations. Maybe these drugs really are going to have benefit more in patients with high-risk disease rather than lower-risk disease. And so maybe it's the fact that the PALLAS trial included some patients with lower-risk disease, and maybe that diluted out the benefit that could have been seen. I'll say it's hard to definitively conclude that, given that we're not seeing a signal even in that high-risk population of PALLAS, but, potentially a factor. Another big factor is, well, are you taking the drug? Obviously, if you're not getting the drug because it's having too many side effects, it's hard to imagine it's going to have any benefit when it's not taken very long. So I think that is a problem with the PALLAS trial, where a little over 40% of patients did have to stop the drug early, and potentially could have influenced why there hasn't been benefit seen. And then I think it leaves us with the question, are there just are these drugs actually different? Is there something different about the efficacy of one over the other? Is one maybe a more potent inhibitor of the pathway? You know, it turns out abemaciclib is actually taken every day. You don't get a day off. Whereas with palbociclib, there's a week off. And so some people have theorized that maybe that week off sort of makes it a little bit not as efficacious, because maybe it allows cancer cells to regrow during that time, that break, if you will. Again, we don't know this. Again, in the metastatic setting, that didn't seem to be an issue at all. It's a very efficacious therapy. But people are just trying to make up ideas for why it could be different in this early disease setting. So I think, you know, we really have a lot more to learn. I think we don't have the answers to really fully explain why we're seeing these differences. There are more theories than anything. And there are lots of other trials that are ongoing in this space. There was a trial that had looked at just 1 year of palbociclib in patients who had gotten chemo before their breast surgery and had some cancer left over at the time of surgery. And then they got their hormone with or without the palbociclib for a year. And we haven't seen data from this trial yet, so we'll have to see if the results are different than PALLAS. There's also another trial called NATALY, which is looking at the third CDK4/6 inhibitor called ribociclib, and that is giving 3 years of the drug instead of 2 years as these other trials, both PALLAS and monarchE, had done. So I think, again, we're going to learn a lot more in the near future. But I think given the findings of monarchE, I have been encouraged enough to think that abemaciclib may represent a new standard for our patients with high-risk hormone receptor positive disease, because it seems like it is preventing recurrence of cancer in that, at least in that subgroup of patients. So, you know, what about triple negative breast cancer? I think we've seen a lot of exciting things come out in breast cancer in general, but one thing that has emerged in triple negative breast cancer has been utilization of immunotherapies. And we've previously seen data prior to ESMO, actually this came out at ESMO last year, of a preoperative trial where immunotherapy, specifically the antibody pembrolizumab, was added to chemotherapy in patients with triple negative disease when they were first diagnosed. And when they randomized patients to get chemotherapy with pembrolizumab compared to chemotherapy alone prior to their breast surgery, what we saw was that when patients went to surgery and we look at how many patients have no cancer left at the time of surgery, we see that that is much more common in patients who got the immunotherapy added to their chemotherapy than if they just got chemo alone. So here you can see we call that having no cancer at the time of surgery, a pathologic complete response. So there are more patients with the pathologic complete response when they got the immunotherapy, and with a difference of about 13% between the two arms. So, you know, a statistically significant difference. And, you know, in metastatic disease, the benefits of immunotherapy have really been confined to patients whose tumors have the PD-L1 receptor on it. But for early stage disease, it seems like that benefit seen whether your tumor is PD-L1 positive or PD-L1 negative, it didn't matter, and that all patients seemed to benefit from adding the immunotherapy. So at this point in time, we've been waiting to see if not only was adding immunotherapy to the chemotherapy improving rates of pathologic complete response, but we also want to follow patients out for the long run and see if it's actually preventing recurrences in the end. And we are waiting on that final data. But I think most people have been very encouraged at this very large difference in pathologic complete response, thinking it's likely to lead to preventing recurrences in the long run. And so at ESMO this year, we saw data from another trial. This time it was looking at a different immunotherapy drug called atezolizumab, and adding it to chemotherapy, again, prior to breast surgery. And here, this trial, you know, found that this was enrolling also patients who had stage 2 and 3 triple negative disease, and found that adding the immunotherapy to the chemotherapy did significantly improve the rates of pathologic complete response. Here you see a difference between the two arms of about 16%. And that this benefit was seen also independently of PD-L1 status. So it didn't matter if your tumor had the PD-L1 receptor or not, your cancer still had benefit from adding the atezolizumab. And here again, they tried to look at the subgroups of patients to see, is one group benefiting more than the other? And I think one characteristic that's been a trend both with the preoperative pembrolizumab trial and with this trial is that when patients have more lymph node involvement, they do seem to derive greater benefit from the immunotherapy. And so when there is higher risk cancer, we're seeing greater benefit from the immunotherapy. This trial tried to also look at this very early time point, was the cancer was adding atezolizumab actually preventing recurrences as well. The study isn't really adequately powered to definitively say this, but at this point in time, there's a trend that there are fewer recurrences with adding the atezolizumab. And then obviously we always get concerned about side effects with immunotherapy. Sometimes we turn on the immune system and it gets a little too revved up and it starts attacking healthy organs and causing problems. One of the most common things we see is thyroid toxicity. And so people can be left with permanent hypothyroidism. That's probably the most common side effect we see. And you can see in this trial that occurred in about 10% of patients who had some thyroid toxicity from the drug. So, it's not an insignificant number. And in fact, in the preoperative pembrolizumab study, this rate was a little higher even. So, we are seeing that there can be lifelong permanent immune-related toxicities, although not frequent, still a potential risk that does have to be monitored for. So, I think this was a very important study. I think it's confirmed what we've previously seen from immunotherapy, that it can improve pathologic complete response rates. And, I think we're waiting again to see if we are really in the long run, once we follow patients over time, preventing these recurrences. And, I think this slide just really summarizes that there have been a lot of immunotherapy trials now that have been conducted in the same preoperative triple negative space. And not all of them have been positive trials. One trial, this NeoTrip study, did not show benefit. It utilized a different chemotherapy backbone. It used two drugs, carboplatin and a taxane, but it didn't have the anthracycline drug with it. And so many of us have wondered that maybe you do need to give the anthracycline with immunotherapy prior to surgery to make that pathologic complete response rate improve. But again, I think we still have lots of unanswered questions here. So the FDA is actually currently reviewing the data for utilization of immunotherapy for preoperative breast cancer. We may get an answer about whether or not that gets an approval, hopefully early next year. For metastatic breast cancer, we also saw a lot of exciting data. We have had our very first approval for immunotherapy for metastatic triple negative breast cancer, and that came last year, and it was based on this trial we call the Impassion 130 trial, where patients with triple negative breast cancer who were newly diagnosed with metastatic triple negative disease were randomized to get chemotherapy with a chemo drug called nab-paclitaxel, or to get that same chemo drug with atezolizumab, the immunotherapy agent. And the trial had demonstrated that there was an improvement in the survival of patients who got the immunotherapy drug if their tumor was PD-L1 positive. What was presented at ESMO was the final survival data, which was really consistent with the data we've previously seen from an earlier analysis of the study, showing about a 7.5-month improvement in survival from using the atezolizumab. And so I think this really just confirmed what we already knew, that adding atezolizumab to nab-paclitaxel was allowing our patients to do better and should remain the standard of care if someone has a PD-L1 positive triple negative breast cancer. But I think what was very surprising that came out at ESMO is I think most of us thought if we had redone the trial and we had swapped out the chemotherapy for a chemo that many of us more commonly use, which is paclitaxel, that we would see the very same benefit. I think that's personally what I had assumed. I thought it may not matter if we used paclitaxel or nab-paclitaxel, and I just assumed this trial would show us that we would see the same benefit that we just saw from Impassion 130. So they sort of repeated the trial against switching out the chemotherapy agent. The challenge is that this chemotherapy agent does require that patients get some pre-medication with a steroid before they get the chemo to prevent allergic reactions to the chemotherapy. Whereas the other trial that used nab-paclitaxel didn't require that steroid pre-medication because it doesn't cause that type of allergic reaction. And so the question really was, would the impact of immunotherapy potentially be different when you're using steroid pre-medication? It turns out that the study showed no benefit to adding immunotherapy when it was added to paclitaxel. It did not improve what we call progression-free survival, so the amount of time someone's able to remain on the treatment before the cancer grows. It numerically improved response rates, but not in a statistically significant manner. And it did not allow patients to live longer. So again, I think this really sort of surprised me very much. And again, I think the conclusion here was there is no benefit to adding the atezolizumab when we switch the chemotherapy. And, you know, I think this is now, again, sometimes we get more questions than answers. And I think it's made us wonder, well, why is this? Is it really just a steroid? You know, we give a lot of chemotherapy with steroids and other cancers, and it with immunotherapy, and it's adding benefit. Is that really sufficient to explain why this didn't work? And the truth is we don't know. You know, it did turn out that most patients did take the steroids for the duration of time they're on chemotherapy, that they didn't stop it. Sometimes the physician will stop that steroid premedication if people aren't having reactions, but in this particular trial, the physicians mostly tended to continue it, so patients were getting exposed to the steroid throughout most of their time on chemotherapy. Maybe that had some impact. Was it something different about the characteristics of the types of cancers that patients had that went on to this trial? Sometimes, you know, it may be that some types of cancers are going to be more sensitive to immunotherapy than others. Was it some difference in the populations of patients that went on to the study that led to the differences in outcomes that we're seeing? You know, again, it potentially could be on paper they looked pretty similar, but, you know, there are subtle differences. Sometimes when a patient may have gotten the taxane drug before for their original breast cancer, that could influence how well the chemotherapy is working now. And sometimes that can be influenced by how long ago that chemotherapy exposure was. And what if, you know, on this trial, patients had received that taxane sooner and maybe had more resistance to taxane than in the other trial. Again, there can be these subtle differences that can lead to the drugs not working. Maybe it was a design of the trial. They did a different design than they had with Impassion 130, where there were fewer patients on the control arm. And so sometimes that can make it difficult to statistically analyze the data. And again, that could have influenced things, and it obviously could just be chance. So, you know, we don't know if this is really something that's truly contraindicated with immunotherapy. Was this chance, or is this, you know, due to the steroids or differences in the types of patients that may benefit? And I think, again, we still have a lot to learn to figure it out. But for the time being, you know, I think the recommendation would be not to give paclitaxel with atezolizumab, given that from this study, we're not seeing benefit. There was also data that came out for metastatic triple-negative breast cancer on a very exciting drug called Sacituzumab Govitecan. This is what we call an antibody-drug conjugate. That means that it takes an antibody that's targeting a particular receptor on a cancer cell, and it links that antibody to a chemo drug. So what happens is the antibody binds to the cancer cell, it gets taken into the cancer cell and releases its chemotherapy into the cancer cell. Some people think of them as smart bombs because they're sort of targeted delivery of the chemo right into the cancer cell. And so a very clever way to think about giving a higher dose of chemo into the cell itself, potentially allowing treatment to be more efficacious. And so we had seen prior studies of this drug. It was from an early trial that had looked at the drug given alone for metastatic triple-negative breast cancer, and the results had been really outstanding. It had shown that the response rate was around 30%, and it was keeping cancer controlled for around 6 months. And this was in patients who had had multiple lines of prior chemotherapy for their triple-negative disease. And so based on those initial findings, the FDA had decided to give this drug accelerated approval just a few months ago. But then the company had to do what we call a confirmatory trial, really proving that this drug is better than standard chemotherapy. And so that's what this trial is the ASCENT trial, compared Sacituzumab Govitecan to what we call treatment of physician's choice, meaning picking a standard chemotherapy drug that would otherwise be used to treat the triple-negative breast cancer. And here you can see that the progression-free survival was substantially longer with Sacituzumab compared to the physician's choice chemo. So 5.6 months compared to 1.7 months. That's how long the cancer was controlled before someone needed to go on to a different treatment. So dramatically different. And even when you look at the subgroups of patients, you can see that, you know, all different types of patients were deriving benefit. It didn't seem like it was just skewed to one type versus another. And then when we look at how long patients are living with their triple negative disease, we can see that they were living longer if they received the Sacituzumab compared to the physician's choice chemotherapy, almost a doubling, you know, 6.7 months to 12 months in terms of survival. Obviously, again, we always have to think about the side effects from these drugs. The major side effect that we see is lowering of white blood cell counts, so specifically neutropenia. So that does occur in more than half of our patients who get this drug. And so a lot of patients, when they get this drug, do end up needing to take a growth factor shot to help keep their blood counts up to be able to continue to get the drug on time, or may need to have a dose reduction. And people can have fatigue and diarrhea. And I will say all my patients have lost their hair when they have gotten this drug. So important to keep that in mind as well. So I think in conclusion, you know, this trial showed that this new drug, Sacituzumab Govitecan, really is far superior to standard chemotherapy, at least in this setting. And that, you know, really confirms the decision by the FDA to approve this drug to treat triple negative breast cancer. So we also saw some other data come out for metastatic hormone receptor positive disease. One of the trials that had an updated analysis was looking at a PI3 kinase inhibitor. So it turns out that about 40% of tumors in patients who have hormone receptor positive breast cancer have what we call a PI3 kinase mutation. That means that this PI3 kinase pathway is turned on in these tumors, and it is potentially driving the growth of these cancers. And so some thought is that, well, if that mutation is present and it's driving the growth, we need to turn off that pathway. And so this drug, alpelisib, is a PI3 kinase inhibitor that turns off that pathway. And so this trial had randomized hormone receptor positive patients to get a hormone therapy, fulvestrant by itself, or to get the fulvestrant with the PI3 kinase inhibitor alpelisib. And when you look at the patients who have the PI3 kinase mutation, we had previously seen data suggesting that the disease was controlled significantly longer, a little over 5 months longer in patients who got the alpelisib with their hormone compared to the hormone alone. But now at ESMO, we saw the data for survival. So the question was, yes, we're keeping the disease controlled longer, but are we allowing our patients to live longer when they take this drug? And technically, there wasn't a statistically significant difference in survival, but, you know, I will say there was almost an 8-month difference in survival between the two arms. So, you know, while again, it didn't meet statistical significance, I think many of us would say that's a pretty clinically meaningful difference between the two arms. And then when you look at the different subgroups, you can see that there did seem to be an even greater benefit in patients who had what we call visceral metastases. So having liver or lung metastases led to even greater benefit of the alpelisib. And here you can see again in what we call the Kaplan-Meier curves that there is a larger difference here between the two arms in about a 14-month difference in patients who had liver or lung metastases. And so, you know, now patients are living over a year longer with alpelisib. It was also delaying the time to needing to take chemotherapy by getting alpelisib. But here again, always important to think about side effects, and the major side effects from this drug do include hyperglycemia. And so, you know, a really pretty significant increase in blood sugars, and many of my patients do require getting started on metformin to help control blood sugars. The other major side effect we see is rash. So a lot of patients will get a rash with this drug, but it turns out that using an antihistamine drug can prevent this rash from occurring, and something we've learned since this trial has been conducted. So, you know, I think again with the trial, this updated analysis is showing that adding alpelisib to the hormone therapy in patients with a PI3 kinase mutation did extend survival by about 8 months in the overall population, and about 14 months in those patients who had liver and lung metastases. But important to remember, it wasn't statistically significant in terms of the actual survival difference. So, you know, I think some of the take-home messages that I saw from ESMO were that adding abemaciclib to hormone therapy for what we consider high-risk hormone receptor positive breast cancer was helping prevent recurrence. So I think an important finding. I think it's important to remember that we haven't followed these patients very long, and we do need to follow them longer to really better understand if this benefit persists with longer follow-up, or maybe if it even potentially could get greater. And so we do need to better understand that. Also, that adding atezolizumab, so immunotherapy, to chemotherapy prior to surgery for patients with triple-negative breast cancer is improving rates of pathologic complete response. This is consistent with data we've previously seen from another trial called the KEYNOTE 522 trial that had shown that adding pembrolizumab to chemotherapy improved pathologic complete response. We do tend to see that adding immunotherapy to chemotherapy has even greater benefit in patients with lymph node involvement. And, I think we're seeing if the FDA is going to decide to approve these drugs based on these differences in pathologic complete response, or if the FDA is going to require a difference in recurrence in the long run, which will take a little longer follow-up to see that benefit pan out. We also talked about the Sacituzumab Govitecan data, really suggesting that it is far superior to standard chemotherapy for pretreated triple-negative breast cancer. And then the drug alpelisib, a PI3 kinase inhibitor, did seem to have a clinically meaningful improvement in survival, but not statistically significant. And again, I think one has to be cautious about the toxicity with alpelisib and sort of weigh that against the potential benefit. So, in my mind, there was a lot of data that came out in breast cancer at ESMO, and certainly all very exciting. And hopefully we're going to see some of these drugs be able to get to patients very soon. So thank you, Maya.
Great, thank you very much, Dr. Tolaney. So maybe, so now we're going to open it up to Q&A. Maybe if we stop sharing, yeah, perfect. We're going to open it up to Q&A. Let me kick it off, and we've received a few questions, so I'm going to go through it. But for those of you that are connected, if you want to ask a question, you can use the Q&A or the chat on the Zoom. So let me just start more broadly. Actually, this is a very interesting overview of the data coming out of ESMO. As a physician, have this really changed, how you go about treating your patients today?
Yeah, so excellent question. And, we always ask ourselves, well, when we go to clinic on Monday, are we going to do something different for our patients based on these data? And, we already knew about the Sacituzumab Govitecan data. That drug already got FDA approval, so I had already been using it prior to ESMO, but these data just confirmed my utilization of it. I think the newer practice-changing thing is the abemaciclib, because to me, patients with high-risk hormone receptor positive breast cancer, obviously we want to do everything we can to prevent the cancer from coming back. And to see that there is this signal that adding abemaciclib is preventing recurrence, to me is very meaningful. And so to me, one of my sort of take-home things is, if I have a patient who has a high-risk hormone receptor positive cancer that would have met eligibility for that trial, the monarchE trial, I would consider using abemaciclib in those patients, given this benefit that we're seeing. I think the data from SOLAR-1 looking at alpelisib sort of confirmed my utilization of alpelisib. In my mind, it means that we should be testing all our patients who have metastatic hormone receptor positive breast cancer for a PI3 kinase mutation. And if they have the mutation, I do consider alpelisib, although be it with careful monitoring for side effects. And then immunotherapy, I think, it remains a standard for metastatic triple-negative breast cancer. The Impassion 130 data confirmed that. And so we should test all our triple-negative metastatic patients' tumors for PD-L1, so we know who will benefit from those drugs. But I think the open question in my mind is, should we be using immunotherapy for our early breast cancer patients with triple-negative disease? Because now we have a few trials that are showing that adding the immunotherapy is improving pathologic complete response in a significant manner. And I think the challenge for me is that I worry about some of these side effects that can potentially be lifelong toxicities. A lot of these patients are young women with long lives ahead of them, and to deal with sort of some of these permanent side effects is what concerns me. And, you know, we also don't know what the implications of immunotherapy could be on fertility for young patients who may want to have children. And so it does still raise a lot of questions in my mind. And, you know, I think, again, the FDA is going to be reviewing these data soon. And so we'll have to see what their decision is about making it standard, or if they're really going to want to wait to see differences in rates of recurrence with longer follow-up before making that decision. So in my mind, I think for a patient with a very high-risk triple-negative breast cancer, it probably is very reasonable to think about immunotherapy. But I struggle a little bit if someone had, you know, an early stage 2 cancer where the benefits may be smaller and you have to weigh that against the side effects that could result.
Okay, great. Another broad question before I go through some specific question. Actually, so it's interesting going back to the alpelisib data and being able, you know, testing for the PIK3CA mutation. I should say that we have done a recent study on people that are using our app for metastatic hormone-positive, HER2-negative patients, asking whether they've undergone genomic testing to see if they have the mutation. And only a third of metastatic hormone-positive, HER2-negative patients have undergone testing. As a doctor today, is it the recommendation that every single patient should, in that category, should get tested for whether they have that mutation to see if that is a treatment options for them?
You know, generally speaking, I'd say my thought is yes, we should be testing our patients for genomic mutations. But at this point in time, the only couple mutations that sort of impact our treatment decisions are the PI3 kinase mutation and if you have a BRCA mutation. Now we do know that in someone who had an inheritable BRCA mutation or even a somatic BRCA mutation, meaning a mutation that occurred in the tumor and not maybe hereditary, that we are seeing benefits from PARP inhibitors in those patients. And so, you know, I think it is important to at least have genetic testing to know if you have a BRCA mutation, and then to potentially get your tumor tested to know if there's a PI3 kinase mutation. That being said, there are patients for whom it is contraindicated to give a PI3 kinase inhibitor, right? If someone has significant diabetes that's not well controlled, we're not going to use alpelisib, in which case one could argue maybe you don't need to test the tumor because, you know, you're not going to be able to give the drug to that patient anyway. So I think we're learning more and more, and I think we're going to learn more about genomic alterations that can influence our treatment decisions. But personally, I am testing all my patients.
Okay, and that's something that, and then I come back to a specific question we just got linked to that answer, but this is also maybe just keeping this last general question here, which is, you know, as you know, Outcomes4Me is all about empowering patients also to have a, you know, a proactive role in their own care and the discussions with doctors. So obviously, you know, being tested is one of them, but, you know, stepping back in terms of just, you know, from what the new, what we've learned from ESMO, any recommendation for patients in terms of starting any kind of conversation with their doctor today based on the data?
Well, that's a good question. I mean, I think if you're an early stage breast cancer patient who had a cancer that was hormone receptor positive and had several lymph nodes involved, you know, the question is going to come up, is there any benefit to adding abemaciclib? So definitely a question that could be considered. You know, I think if you have metastatic breast cancer, we talked about making sure if you're hormone receptor positive that you consider genomic testing to know if alpelisib may be a benefit, to make sure you get germline tested to know if you have a BRCA mutation. If you have triple negative disease that's metastatic, to think about making sure your tumor gets tested for PD-L1 to know if immunotherapy may be beneficial. And then if you have triple negative metastatic disease, to ask about Sacituzumab Govitecan, given the dramatic benefits that have been seen. So, you know, I think those are probably the things that one could think about.
Okay, great. I do want to come back to the PIK3CA. We just got a question here on the chat. So I'm going to read the question from Janet. I have metastatic HER2 positive hormone negative breast cancer to the bone. I tested positive for PIK3CA. I'm on the third cycle of alpelisib and level 3 hyperglycemia is now present. Not having much luck controlling the hyperglycemia, but tumor markers have decreased drastically. Have you seen success in one treatment or another with the hyperglycemia pills or insulin?
No, it's a very good question. And unfortunately, this is a common problem with alpelisib. And so, tight glucose monitoring is really recommended. And we do check patients, what we call their hemoglobin A1C up front. We check fasting glucoses routinely. And then usually what has been most beneficial is initiation of a drug called metformin, which does help reduce the glucose levels. And it turns out it's more effective than insulin is with high blood sugars related to alpelisib. And so, usually I do work carefully with our endocrinologist to help manage this, but I generally would recommend metformin in this situation.
Okay, great. So we got actually quite a few questions submitted before the webinar on TDM1. So I'm going to group them all into I'm just going to go through all of them. That way you can address them all. So the questions were, is TDM1 now the more effective treatment for HER2 positive cancer than herceptin and perjeta when residual disease is present after chemotherapy and surgery? Another question, the Catherine trial, your views. What if patients are unable to complete 14 cycles of TDM1? Should they then resort back to herceptin and perjeta? The other question, the third question, so 3 questions on TDM1. Is TDM1 now the more effective treatment than herceptin and perjeta for HER2 positive breast cancer than has residual disease after surgery? Sorry.
Yeah, no, that sounds like those are all along the same theme. Yeah. So basically, I think the question is that, when someone generally who comes in with stage 2 or 3 HER2 positive breast cancer, we usually give them some chemotherapy with often herceptin and pertuzumab with it prior to breast surgery. And it turns out if they go to breast surgery and there's still some cancer seen at the time of breast surgery, that's what we would call residual disease, meaning it didn't all go away, then we know that giving TDM1, which is an antibody drug conjugate, is better than giving herceptin in that particular setting. So that was based on that trial that you mentioned, the Catherine study, which took patients who had cancer that was left over at the time of surgery and randomized them to get 14 cycles of TDM1 or to just continue on herceptin. And so I would agree that I do think TDM1 really should be the standard in patients who have cancer that's left behind after getting chemotherapy and anti-HER2 therapy prior to breast surgery. Certainly there are lots of questions that were permutations on that, which is, well, what if I can't get through all those 14 cycles of TDM1? And it turns out that 30% of patients actually in the Catherine trial couldn't get all 14 cycles. And despite that, we still saw a 50% reduction in recurrence. So we do know that even if people didn't finish, we were still seeing benefit in the overall population, which is reassuring. But they did allow patients to, if they stopped their TDM1 for side effects, many of them actually just replaced it with herceptin. And so, in my practice, if that happens, I often will stop the TDM1 and use herceptin pertuzumab in that particular setting to complete the year of therapy if they couldn't get all their TDM1 in. And so, sometimes that unfortunately does happen. But again, it is a highly effective drug that we do use in this setting.
Okay, great, thank you. We did have a number of questions in different settings on recurrence. And I'm going to go through them because actually, we talked about one subtype where, there was an impact on recurrence. So one of the questions is there a link, actually both questions, is there a link between estrogen positive breast cancer like HER2 positive and a dairy-free diet to reduce the chance of recurrence? So that's the first question. The other is a different subtype of breast cancer. So
I think the data isn't substantial enough to recommend a dietary change in someone with HER2 positive breast cancer to tell them that they need to do specifically, for example, a dairy-free diet. So I do not recommend that at this point in time to our patients.
Okay, and then another question about a person that I'm going to read it as is. I am nearly 55 years old. In 2016, I was first diagnosed with stage 2 hormone-positive HER2 negative breast cancer. I was treated with lumpectomy, chemo, and radiation. 2 years later, in 2018, I was diagnosed with stage 2 triple negative breast cancer and treated with only a mastectomy. What is the recurrence rate for triple negative breast cancer as a second breast cancer diagnosis? Is that something, well, actually, that brings the broader question. Do we really understand recurrence rate? We do, and maybe let me just broaden it up a little bit, because we do get quite a bit of questions, which is fully understandable, about recurrence rates. And one thing that I personally found always difficult about assessing recurrence rates is by the time you get a recurrence to have the hard data, treatment has changed. So people were treated probably under a different regimen than where science is today. So maybe answering this, but maybe broadening it around how to think about recurrence. Yeah.
I mean, I think if we specifically think of this particular question about risk of recurrence from a triple negative cancer, it depends on a lot of factors that I probably don't have substantial information to give an accurate number, because we take into account a lot of features to make that determination in terms of tumor size, lymph node involvement, grade, is there lymphovascular invasion, nodal involvement, all those sort of factors kind of get put into one to sort of help us understand risk of recurrence. And so usually we can try and estimate that, again, as you alluded to, based on sort of multiple trials that have been done in the past. But the question is also important in the setting of having another prior cancer. And I think the thing is, we almost look at them as the two different risks, because there's a risk of having a recurrence from the original cancer, and then there's a risk of recurrence from this new cancer. And those are individual risks. And so, you know, we sort of have to think of them together for that particular situation. But, you know, I think your point is also a good one in terms of, well, how do we actually calculate risk of recurrence as data evolves so rapidly, and that, you know, usually we're looking at rates of recurrence over 5 to 10 years. And so our numbers may not be so accurate in a modern era where drug treatment is different. And I think it's true that, you know, if you look at, for example, the abemaciclib data, right, we're going to be basing our risk of recurrence on what we know from, you know, basically how the control arm has performed, right? How patients who got standard hormone therapy over years have done. And that's the numbers we have solid data for. But we're not going to know what the risk of recurrence is after someone's had 2 years of abemaciclib in 5 to 10 years, because we need 5 to 10 years of follow-up to get that data. And so you're right that, you know, with some of the newer agents that come out, that long-term follow-up isn't quite there yet.
Yeah, and so going back to some of the, and maybe just wrapping up with one or two questions, and then we'll wrap it up as we're coming towards the end. But going back to actually some of the older drugs, we got a question here from the audience here, from Anne-Marie, and I'm going to read it. Hi, my diagnosis is ductal carcinoma in situ, no lymph node involvement, tumor size 3 by 3 by 2 centimeters, no metastasis, grade 3, stage 0 stage, hormone status ER weak positive, PR negative. I am taking tamoxifen. How reliable is tamoxifen?
Yeah, so you know, in general, maybe not so specific to this case, because again, I think I'd want a couple more pieces of information, but in general, tamoxifen is a very highly effective drug. And when someone has DCIS, what it is it's cancer cells that are really confined to the duct. And so, you know, what we're worried about is, you know, if there's some cells that are somehow left behind, could those cells either come back as another DCIS, or could they actually come back as an invasive cancer? And it turns out that about half of the recurrences in people who have DCIS are going to be DCIS coming back in the breast, and half of the recurrences could actually be an invasive cancer, which is what we obviously want to avoid. And it turns out that when someone has a hormone receptor positive DCIS who's had, you know, a lumpectomy and radiation, so still who has their breast, that using tamoxifen can help prevent that risk of recurrence by half. So it is really very beneficial. And it turns out there's some newer data that suggests that even low dose tamoxifen may be beneficial in this population with even less side effects. So it is a discussion that we're having with our patients based on the data available, whether or not that may be appropriate for them or not. But generally, yes, tamoxifen is a highly effective treatment for hormone receptor positive DCIS.
Okay, great. One last question, and we're gonna wrap it up, which we got before the webinars. It's about side effects. So, are the side effects of taking aramycin exemestane, such as joint swelling and pain, bone pain, high blood pressure, and equilibrium balance issues, as an adjuvant for hormone positive, HER2 negative breast cancer, permanent or temporary?
Oh, excellent question. So I think the answer is kind of twofold, because some are permanent, some are temporary. So, you know, the joint aches and hot flashes and sort of achiness that generally comes with these aromatase inhibitors is generally temporary, meaning if you were to discontinue the drug, usually several weeks later, that those symptoms would dissipate. But these drugs are, excuse me, lowering your estrogen concentration. And so that does put your bones at risk for developing osteoporosis, which is a potentially permanent toxicity. So some things are generally temporary, but the issue about osteoporosis is potentially a permanent long-term toxicity.
Okay, and then actually, since we're talking about ESMO, we got questions from some of our patients saying, you know, can they attend the conference?
Oh, yeah.
Yeah.
So yes, patients can attend these conferences. I think one thing that has come about is, you know, registration fees for these conferences are not cheap. And I know with the sort of move to a virtual platform, there have been some lowering of costs that have come about for different registrants. And so hopefully that will be the case next year, as I'm guessing we'll have mostly virtual meetings, and hopefully these costs will stay down.
Would you recommend people attend them, patients attend them? Are they helpful? I know they're targeted to the doctors. Yeah.
I mean, I certainly, if someone has interest, I definitely would encourage you. I think the only challenge is that you're right, that the presentations are really geared towards oncologists. And so the conversations and the interpretation are sometimes not it's definitely not in a patient-friendly format. And so sometimes that may make it challenging to interpret, you know, and so I think, again, it depends on the patient preference. Sometimes I worry it can make people anxious, you know, to listen to things without having it in context. And so I think it depends on the individual person.
Great. Well, first of all, I want to thank you tremendously for this. I've learned a lot, and I'm sure everybody on this call did too. So thank you for taking the time to join us. And thank you for everyone who has participated today. If anyone has any follow-up questions or thought, please email us at questions@outcomes4me.com. We'll be also sending out a survey after this for feedback on what you would like to hear for future webinars to cover. We will also make sure that these videos are available on our app, along with a blog recap if you want to revisit or share with others. And finally, to make sure you don't miss any future updates, make sure to download the Outcomes4Me app and enable your push notifications. Thanks again, and thank you, Dr. Tolaney. Have a great day.
Thank you so much.
Thank you.